All right, let's talk about something that literally walks into your pharmacy every single day: common foot problems. Today, we're going through a practical, step-by-step playbook to help you nail that patient consultation every time. And just to give you an idea of how common this is, get this. When it comes to just bunions, 1 in 3 adults over 65 is dealing with them. That is a huge slice of your community looking to you for some real help and solid advice.
So picture this. A patient walks up to your counter. They say their foot hurts. It's vague, right? It could be a dozen different things. This is that moment where having a system, a playbook, can make all the difference. So where do you even start?
Okay, let's get right into it. The whole game plan, everything we're about to talk about, rests on this one critical first step: a really good assessment. Before you even think about recommending a product, you have to play detective.
And that means looking at two things. Yep, you've got to look at their actual foot, of course, to see what the lesion looks like. But, and this is the part that often gets missed, you absolutely have to look at their shoes. The source material is crystal clear on this. Bad shoes are the #1 villain for most of these issues.
So, when you're checking out their shoes, start with the basics. How do they stay on? Do they have laces, buckles, maybe some Velcro? Anything like that is way better than a simple slip-on, because it actually holds the foot in place and stops it from sliding around, which, is what causes all that nasty friction and pressure.
Next, you want to check a couple of key measurements. The heel shouldn't be much higher than 1.5 inches, or about 3.75 centimeters. Any higher and you're just shoving all the pressure onto the front of the foot. And then there needs to be about 1/2 inch of space, that's 1.25 centimeters, between their longest toe and the very end of the shoe. Give those toes some room.
Now this is a big one, the toe box. It's not just about length, it's about width. You see that big joint at the base of the great toe? That's the widest part of most people's feet. And it needs to sit comfortably in the widest part of the shoe. If that area is getting squeezed, well, you're basically rolling out the red carpet for a bunion.
And here is a golden nugget of advice to pass along to your patients. Tell them to go shoe shopping in the evening. Why? It's simple, really. After you've been on your feet all day, gravity makes them swell up to their biggest size. Buying shoes then means you're getting a fit that's going to be comfortable from morning till night.
Okay, so you've looked at the shoes, you have a pretty good idea of the cause. Step 2 is figuring out exactly what you're looking at on their foot. A lot of these things can look pretty similar at first glance, but they have some key telltale differences.
Let's start with a corn, or a heloma if you want to be technical. It's not just a random patch of thick skin. The dead giveaway, and what makes it so darn painful, is that it has a hard central core that's shaped like a cone. And that cone points inward, pressing right on the bone and nerves. Ouch. And this is a super important distinction because corns and plantar warts get mixed up all the time. Here's how you tell them apart. Look at the tiny lines on their skin, the skin ridges. On a corn, the lines go right through it. But on a wart, the lines are pushed aside. They have to go around it. Also, if you were to gently scrape the top, a wart would have little pinpoint bleeding spots. A corn won't.
Now, even corns have different personalities. You've got your hard corns, which are usually on the tops of your toes or the bottom of your feet. And then you have soft corns, which are usually way more painful and hide out between the toes. A soft corn is basically just a hard corn that's gotten all soggy from sweat, making it feel kind of rubbery. Now, a callus is a different beast entirely. It's still thick skin from pressure, but here's the key. No central core. It's a much wider, more spread out area of thick skin, and patients will usually complain about a burning feeling, not that sharp, focused pain you get from a corn. Next up, the bunion. Now, we're not talking about a skin problem anymore. This is a structural thing, a deformity of the joint. The big toe joint starts to angle outwards, which pushes the toe itself inwards, creating that classic, painful red bump on the side of the foot.
And finally, the infamous ingrown toenail. This happens when the edge of the nail, usually from being cut wrong or squeezed in a tight shoe, starts growing right into the soft skin next to it. The body freaks out, treats it like a splinter, and you get all that redness, swelling, and a whole lot of pain.
So, you've assessed the shoes, you've identified the lesion, now what? Well, it's time to open up the management toolkit. And we've got a whole range of options, from things that don't involve drugs at all to some specific pharmacologic strategies.
But before we even talk about products, let's be absolutely 100% clear. For corns, calluses, and bunions, the single most important thing to do is fix the root cause. And that means getting the patient into shoes that actually fit. Honestly, a lot of the time, that's the only treatment they'll need.
So besides new shoes, what else can you suggest? Well, for corns and calluses, you can recommend gently using a pumice stone after a good soak. There are all kinds of protective pads and silicone sleeves to reduce pressure. For those nasty soft corns, a little bit of lamb's wool tucked between the toes can work wonders. And for prevention, especially with ingrown nails, you have to tell them, cut your nails straight across, not curved. Now, if you do need to bring out the big guns for a corn or callus, salicylic acid is your go-to. But how they use it is crucial. Tell them, first, soak your foot. Second, dry it really well. Third, and this is important, protect the healthy skin around the corn with something like Vaseline. Then apply the product, but only on the hard skin. And they can do this every day for up to 2 weeks.
This is a great little cheat sheet here. For corns and calluses, you've got salicylic acid and good moisturizers with urea. For a painful bunion, it's all about managing the symptoms with things like acetaminophen or NSAIDs and ice packs. For an ingrown toenail, while they're waiting to see a specialist, a topical antiseptic can help keep infection at bay.
And that brings us to our final and, you could argue, our most important step, knowing your limits. You have to be able to spot the red flags and know when it's time to stop and refer that patient to a podiatrist or their doctor. This is all about patient safety.
And this part is non-negotiable, folks. Any patient with diabetes or poor circulation should not be self-treating their feet, period. Any signs of infection, like pus or redness that's starting to spread, immediate referral. If a corn isn't better after 2 weeks of treatment, it's time for a referral. And the source is also very clear. Any patient with a true ingrown toenail needs to see a professional.
And the source gives us a really clear timeline to work with. When you recommend that salicylic acid product, set an expectation right then and there. Tell the patient, look, if you don't see this getting better in about 2 weeks, you need to stop using this and go see a specialist.
So, let's end on this thought. Yeah, it's great to know which product treats which problem. But your biggest impact? It might just be in prevention. Think about it. If you make that initial assessment, that footwear check, the core of your counseling every single time, you're not just solving today's problem, you're giving your patients the tools to prevent a lifetime of future foot problems. Thanks for tuning in to this explainer.